Hello everyone, we're about to start. So this week we're going to be going through joints, and we'll talk about the different types of joints, cartilage, and the healing of cartilage specifically. So if we start with the contents, so what we'll be looking at today is a summary of joint development, so how we get to joints. The anatomy of a joint, so we're going to have a look at a synovial joint, what it looks like. Talk about the different types of joints. Talk about cartilage, so its composition, its structure, the cells in the cartilage, and the healing. And then go through some sample questions as always. And there'll be time for questions and answers. If you have any questions as we go through with this, just write them down into the live chat, and I'll go over them. Okay, moving onwards. So joint development, so if you've watched my video on embryology, so this is just a quick recap. So the origin of joints comes from this limb constriction, so the limb segments become constricted, and the mesenchymal condensation between these two bones starts to condense and cleave, and it forms the joint capsule. This is a simple synovial joint. And in the joint capsule, we'll have something called articular cartilage, we'll have a synovial cavity filled with synovial fluid, and it all wrapped together inside the joint capsule. Within this, we can also have accessory features such as ligaments and menisci, so menisci in the knee, ligaments in nearly every single joint, which helps strengthen or improve the collision with the joints. So over here we have a simple joint, so this could be a joint in the finger most commonly, and it's a simple synovial joint. Now we have two articulating bones. This is a bone number 1, bone number 2, and we have some articular cartilage right there, right here. We also have, as I said before, a synovial cavity which is filled with the synovial fluid. We also have a synovial layer of the joint capsule and a fibrous layer of the joint capsule. And this fibrous part is continuous with the periosteum. So this periosteum, it keeps coming back to us. It's what attaches tendons and muscles to the bone, but it also encapsulates a joint. So periosteum, very important. It's a connective tissue. And so the cartilage here particularly is hyaline cartilage, it's articular hyaline cartilage, and its job is to reduce friction and to absorb shock. And it does this through its properties. It's both the cavity itself filled with synovial fluid, but it's also the cartilage itself and the way it's structured. We have the synovial membrane right here, and what happens here is that it produces something called synovial fluid. And this essentially lubricates the joint. So if you can think about it like in a motor or in a piston, you need to have lubrication in order to make it run smoother and to reduce friction. And this reduction in friction enables the joint to move more easily and to recruit fewer muscles and fewer energy. Now, the other thing is that one point is to lubricate the joints, but another one is that it acts as a medium to feed chondrocytes. So chondrocytes are the cells which are found within the cartilage, and essentially there's no blood supply into this area. This is avascular, right? So we don't have blood supply going this way. That's not a thing. So it's avascular. And in order to get nutrients for the chondrocytes, which are all sitting around there, you have this synovial fluid, which gets replenished by the synovial membrane. The outer region here, outer fibrous region, provides flexibility, prevents dislocation, and is also then arranged into powerful ligaments. And these strong ligaments make sure that it stays in place and that the joint doesn't get dislocated, or that the joint moves in the appropriate direction. Now the synovial fluid itself is very special. It contains hyaluronic acid, which is secreted by the synovial cells, and once again its function is to lubricate and thereby reduce friction, whilst at the same time providing nutrients for the chondrocytes. So if we move on, this is what it looks like in a finger joint. And we can see this articular cartilage right here. We have the synovial joint very subtly here. We have a fibrous membrane, we can sort of see it here, and a synovial membrane on the inside right there. And we have the two bones which articulate with each other. So it's always good to see a diagram, but then what it looks like in real life or in a cadaver. So there are many accessory structures around the joint. And the first one we're going to talk about are ligaments. So ligaments are dense, they're regular connective tissue, and what this means is that they're aligned in a regular fashion, much like tendons. And their function is to resist straining that may damage the joint. And a very good example, this is from Teach Me Anatomy picture, is the iliofemoral ligament and the pubofemoral ligament in the hip, and the ischiofemoral ligament. And the naming is basically where the origin and the attachment points are. So iliofemoral goes from the ilium to the femoral head, pubofemoral from the pubis to the pubibone to the femoral point, and here is from the ischium to the femur. Now the hip joint is very important. It's a strong joint, it's a weight-bearing joint, and we need it to be quite strong. So these ligaments here ensure that we do not get a dislocation of the hip. Now you can imagine, for example, if you have to do a hip replacement, that dislocating this requires quite a lot of strength, and therefore you need to have specific surgical techniques in order to do so. But here it provides the strength for weight bearing. In the shoulder, we have the shoulder joint, we have the rotator cuffs rather than the ligaments, and they provide additional stability. But the reason that the hip requires all these ligaments and not the shoulder is because it's weight bearing and we stand on this, and therefore we need our whole body to be stable here. Additionally, we have something called bursae fatty pads. So I've talked briefly about bursae in the shoulder, in the rotator cuff. So their features are that they line the synovial membrane and they're filled with fluid, and these fluid-filled sacs, they can sit in many different areas. So commonly, you have it in the knee, you can have them between skin, between muscle, between tendons, or over an underlying bone. And you can have, so for example, in the femur and tibia and around the knee joint, we have a suprapatellar bursa, which is above the patellar tendon. We have a subcutaneous prepatellar bursa, so this is it's the fatty pad on the knees, it's like a knee pad. We have also below the tendon and above the tendon, so intrapatellar, subcutaneous. We also have a bursa around the knee and also on the side. And all these do is to ensure that all the components are not rubbing against each other, and to reduce the friction and to allow for improvement in the range of motion. We have this also in the shoulder, where it helps to sort of cushion the rotator cuff. Now these things, these bursae, can become inflamed. As you can imagine, they are either through infection or irritation because they're overused, or you can have a puncture there and they can get infected and they become inflamed, and this is called bursitis, so inflammation of the bursa. And once we get bursitis, it's quite irritating, and it ranges from just mild discomfort to requiring surgery to sort of cut out the inflamed part. Moving on. So joint classification. So we have a lot of different types of joints, and there's mainly 6 different types of joints. So we'll start with the pivot joint here. So the pivot joint is quite unique, is because you have a rounded end and the bone protrudes onto sort of sleeve. So this could be a tendon or a bone. So an example of a bone would be that axis and the C1 and C2 rotating between the 2 vertebrae. Or another example could also be in supination in the radial ulnar joint, where the radius and the ulna move like this to allow supination. And the rotation is along the longitudinal axis, so that means, draw a line, if we draw a line straight down through here, it rotates on its own axis. And one of them is the C1 and C2, and the other is supination on the radius and ulna. A hinge joint, so a hinge joint are very simple. It allows uniaxial movement. So this means movement in one axis. As we can see here in this arrow, it allows for flexion and extension. This could be in the elbow, ankle, finger, knee, and it's a and the knee specifically is a modified hinge joint because you also have the patella there. So it's a slightly special type and special case. But a hinge joint is just basically extension and flexion. Then we have something called the saddle joint. So a saddle joint is a type of joint that allows for quite good movement. It allows flexion, extension, but also abduction and adduction. And a good example of this is in the hand. So you want to have flexion, extension, but also abduction, adduction, and it's between the metacarpals, and particularly the trapezium carpal bone and the first metacarpal bone. And it allows for this gliding and sort of movement where they can allow flexion, extension, and abduction, adduction, all the things you would want in the hand. We move on to condyloid joints. So condyloid joints right here are on oval surfaces, and so this is where you have an oval sort of depression here, and it allows biaxial movement. So what that means, it allows a movement in one axis and then in another. So this could be your flexion, extension, and abduction, adduction. It is very similar to the saddle joint, but the saddle joint is not oval. That's unique to the condyloid bone. And a good example of this is the wrist joint, so the radius and carpal bones of the wrist, the metacarpophalangeal joints, and metatarsophalangeal joints, so in the foot. We move on to a plane joint. So this is this joint right here, so a plane joint, and this is between the tarsal bones most commonly, and it allows sliding in two axes, so in this direction and up and down. And one of them could be intercarpal bones, intertarsal bones. It can also be the ones in the shoulder, so the AC joint that allows in this direction. However, this joint does not allow for a lot of movement. It resists movement because it's to create stability in the shoulder. And also the sternoclavicular joint. It allows some movement, but not a great amount of movement in the shoulder. And this is to maintain stability, so it resists movement in that case. Finally, we have the ball and socket joint, which is similar to a condyloid, but it allows movement in all directions. So we have a ball, we have a socket, so this is the simplest type of joint we can also look around, and it moves in this direction, it moves in this direction, up, down, and it can also go in circle. So it's multi-axial, abduction, adduction, flexion, extension, therefore also allowing circumduction, but also rotation. And the shoulder and the hip joints are the two examples of this. So in the order of movement, ball and socket is the most mobile. The difference in the shoulder and the hip, as I've said before, is that the shoulder requires much more range of motion, and that sacrifices stability, which is why we get pathologies in the shoulder. Whereas in the hip, it's much more stable. But since it's much more stable, if there's inflammation, or if we get osteophytes or burrs in the bone or spurs, that becomes irritating, and you can get inflammation in the hip. But overall, we have 6 different types of joints: plane joint, pivot joint, hinge joint, saddle joint, condyloid, and ball and socket. So now we'll talk about cartilage. Very briefly, that was joints. Now we'll talk about cartilage. So there are 3 types of cartilage. We have the hyaline cartilage, and this is the cartilage we find in the skeleton. So this could be your articular cartilage in the shoulder. It could be costal cartilage. It could be the growth plate, but also extraskeletal features such as the trachea is made up of hyaline cartilage, the larynx, but also the nose. So we also have the nose. So these are all hyaline cartilage. For elastic cartilage, we have the ears, and the epiglottis. So those are the two examples of elastic cartilage. And fibrocartilage is most commonly, you look at menisci and intravertebral discs. So those are three types. They have different compositions. However, for the majority of this presentation, we'll be focusing on the hyaline cartilage, which is found in the joints. So the articular cartilage is 95% ECM. So whereas when we had bones or tendons, it was a split of 70 to 30, this is 95% extracellular matrix and 5% cells. So 70% of this is water and 30% are solids. And the solids here are collagen type 2. So in bones and in tendons, it was collagen type 1. Here it's collagen type 2. And we also have ground substance, proteoglycans, and glycoproteins. Now what's important to note here is that the extracellular matrix of collagen type 2, or of cartilage, is that it's collagen type 2 in a sea of a gel of proteoglycans. So how this works is that we have our collagen fibers right here, and these collagen fibers have these little projectiles of hyaluronic acid, and this is the hyaluronic acid, and it's linked to the collagen, and on this hyaluronic acid chain we have all these glycosaminoglycans, so GAGs, which are a type of proteoglycans. And what they do is that they increase the surface area and they cause aggregation. So the collagen fibers, they start aggregating. And what this really does is it creates a negatively charged aggrecan. So this whole thing is called an aggrecan. So this negative charge attracts water because water has a positive charge with the hydrogen ions. So it attracts water. And this negatively charged aggrecan, it's just huge protein, it provides this cushioning property due to the attraction of water, and therefore it is very good at cushioning loading forces. So the whole goal of the cartilage is to attract water, and it's to that point that 95% of the cartilage is ECM. A very small fraction of the composition of cartilage is cells, it's 5%, and these are chondrocytes. And these chondrocytes, they sort of live in this gel, as we talked about before. And the key sort of substances here would be chondroitin that they produce, chondroitin, but also keratin sulfate. And this is what is attached to the hyaluronic acid. So the hyaluronic acid, so that's your HA, and you have all these other attachments towards it. And it looks like a brush. And this brush is negatively charged, which attracts water. So H2 gets attracted to that. And what this means is that we have this negatively charged, we have these chondrocytes in between, and the fact that there's so much water enables it to have this cushioning effect. So here we talk about it a little bit further. So once again, we said that it's type 2 is a gel proteoglycans, and the key chains are hyaluronic acid, chondroitin sulfate, and keratin sulfate, which produce something called an aggrecan. So an aggrecan is just this big sort of mega structure comprised of your collagens, hyaluronic acids, chondroitins, and keratin sulfates. So every sort of collagen fiber has many of these aggregans. So the next step is cartilage homeostasis. So we have these chondrocytes right here, and much like in bone repair, we have degradation and we have synthesis. So for degradation, we have enzymes which break down things. So in the bones, it was osteoclasts. In tendons, it was macrophages and other local cells. Here we have collagenases, gelatinases, aggreganases, and TIMPs, which are called tissue inhibitor metalloproteinases. All of these things are essentially released by the surrounding cells, either by the chondrocyte or the stromal cells, to cause degradation of the tissue. So this is the sort of repair remodeling phase. And on the other hand, you have synthesis, and that's also done by the chondrocyte, and you need collagen, proteoglycans, and proteins to form up the ECM. Now, the promoters of degradation are pro-inflammatory. So this is your interleukins IL-1 and TNF-alpha. And as far as interleukins go, all you need to remember is IL-1, TNF-alpha, they cause inflammation. They recruit inflammation from your macrophages, they recruit inflammation from other cells, and they propagate inflammation. They're part of repair. Now, for synthesis, when things are trying to put back together, you try to build up the collagen, it's your IGF-1 and TGF-beta. So these are growth factors, right? So growth factors promote, whereas cytokines promote inflammation. Now we also have inhibitors. So for degradation, we have glucocorticoids, which inhibit. So this is why corticosteroid injections are so effective. You go into the joint and you inject right into the joint, and it decreases the activity of inflammation. So it acts on, so it does this in two ways. So it inhibits inflammation, but it also inhibits the degradation by targeting the cells that cause the degradation. Now when we look at inhibitors of synthesis, it's just the cytokines. So the cytokines, which we talked about here, they can become inhibitors of synthesis. I think that makes sense. Now NSAIDs are tricky because NSAIDs, they target the arachidonic pathway. So the arachidonic pathway is this huge pathway, and you have all these prostaglandins. And you have COX-1 and COX-2. And some parts of the NSAIDs inhibit the degradation because of those prostaglandin pathways. And some parts of the NSAIDs functions promote synthesis. So it sort of goes both ways. But what's key to remember is that degradation is caused by enzymes, whereas synthesis is caused by chondrocytes building stuff. They require material. Promoters of degradation are inflammatory, so that's your IL-1, TNF-alpha cytokines, whereas promoters of synthesis are growth factors. So that's what the GF stands for. So IGF-1, TGF-beta. Inhibitors, you have glucocorticoids, they prevent degradation, and this is because they stop the inflammation and they target the cells which cause the inflammation and the degradation, whereas cytokines promote degradation and thereby inhibiting synthesis. So the next step here is cartilage repair. So we're going to talk about some principles of cartilage repair. So in order to repair cartilage, you need the injury to go to the subchondral bone. So the subchondral bone is the bone that's just beneath the articular cartilage. So what you need is that it has to go all the way like so. Now when this happens, the chondrocytes from the periosteum become recruited, right? So you get it from the periosteum rather than within the cartilage tissue. And this is once again because we have such poor vascularization of the cartilage. So you need to penetrate the subchondral bone, which has good vasculature. Once this happens, you get inflammation. So synoviocytes, which are the cells lining the joint, and also other local cells start releasing factors, and these cause inflammation. So it's inflammatory cells, both from the synovium and from the periosteum. They produce cytokines, which are inflammatory mediators. Once we get cytokines, it starts to attract cells and other inflammatory cells, and this causes further inflammation. So it's a danger signal. So it's to propagate the inflammation and get all the cells homing into the site. Now what happens then? So we have all of this recruitment of osteoclasts to reshape the bone, but we also start getting chondrocytes to migrate to the zone of injury. And they start synthesizing collagen type 2. Now the cartilage then gets remodeled with the collagenases and the proteases as we talked about before, and essentially the cartilage is repaired. Now this is a very slow process because in order to get good healing, we need good vasculature. And if we have poor vascularization, well then we will have poor healing. And this is one of the key reasons why cartilage heals very poorly. And the other reason is that in order for cartilage to heal, you must penetrate the subchondral bone. So let's do a quick recap. So injury type must penetrate subchondral bone. The vascularization for cartilage repair is very poor, so therefore you need to recruit cells, surrounding cells. So inflammation starts from cells in the synovium, so within the joint, and the periosteum around the bone, and they produce cytokines. Now chondrocytes start migrating to the zone of injury, and they produce collagen type 2. And as a result, we have synthesis, we have this inflammation, repair, and the third is remodeling. This is the same in bones, in tendons, and in muscles. It's inflammation, repair, and remodeling. It's these three things that you should remember. And once we get to remodeling, that's the collagenases and proteases, which degrade everything to make sure that it's in the right sort of within the correct architecture of the cartilage. So that's the first part of our of this video done. So now we're going to move on to some sample questions. If anyone has any questions on anything that's been covered so far, do write them down in the live chat, and I'll get to them. But if not, I'm just going to move on here. So we're going to talk about how does the structure of the joint ensure its function. It's a typical question. What you want to talk about is the joint in its entirety. So sometimes you can draw a diagram, but that's not always necessary because it takes a lot of time, and you could just do it with words. So you want to talk about the synovial cavity. So the synovial cavity ensures that you have the movement of the joint. That's called diarthrosis. We also have the articular cartilage, articular capsule, synovial fluid, and the extra the accessory sort of tissues. So with the synovial cavity, we will talk about diarthrosis, which is a free movable joint. That's the purpose of the synovial cavity, so that you have space for the movement of the two bones. Articular cartilage is made up of hyaline cartilage, which covers the articulating surfaces. It has cushioning forces due to the fact that you have ECM that's heavily contains water, and it reduces friction by absorbing shock. Articular cartilage have two layers, outer fibrous and inner membrane. Outer fibrous is dense collagen fibers, and they prevent dislocation, improve flexibility, and they're attached to the periosteum, and they thicken the continuation of the capsule. And eventually this capsule and this fibrous layer becomes a ligament. Now this ligament is of great tensile strength, and it ensures that we can have heavy loads on our joints. Inner synovial membrane is composed of elastic fibers and fatty padding. So some joints might have extra adipose tissue, so like the knee. This is where bursae can come in as well. Finally, we have the synovial fluid, which has this hyaluronic acid. It's secreted by the synovial membrane cells, and essentially it's a thin layer over the surface of the cartilage, and over the surface of the capsule, and its function is to reduce friction by lubrication, absorb shock, supply oxygen and nutrients to the chondrocytes, provide phagocytic cells for maintenance of the joint and to regulate the inflammation and repair, and it also exists to define mobility. So the more viscous your synovial fluid, so the more thick it is, the less mobile you are. So if you can think about it, imagine your bones are moving in something very viscous. So honey is very viscous. It's quite difficult to move through honey. It's a law of resistance. Whereas if it's less viscous, right, you have higher mobility. So the fluid inside there is important, because the more viscous it is, the more difficult it is to move. And in elderly patients, or in people who have sedentary lifestyles, or people who have poor mobility, their viscosity of the synovial fluid will go down drastically, and therefore it will dry up. This is what they say as when the joint dries up, and you will have poor shock absorption and poor lubrication. So it's very important to maintain viscosity, and you do this through exercise and and being active. So next question that we have here is describe the composition of the 3 types of cartilage. So we talked about the hyaline cartilage, fiber cartilage, and elastic cartilage. So hyaline cartilage has type 2 collagen. It's bound to these hyaluronic acid chains. It's the diagram that I showed you here. So that's your hyaluronic acid, and you have all these fibers creating aggregans. This is keratin sulfate, chondroitin sulfate, and they're found in the growth plate, nasal septum, larynx, and articular cartilage. Fiber cartilage is also type 2 collagen, but it's aligned with chondrocytes. It's found in your intervertebral disc, sternoclavicular joints, and pubic symphysis, so it joins bones together, very important. And elastic cartilage is from elastins. It's a type of fiber and aggregans, and it enables that the cartilage is more flexible. This is your epiglottis, external ear, and auditory tube. So yeah, so to summarize, hyaline cartilage, you have your chains, you have your keratin and chondroitin sulfate. Fiber cartilage, it's collagen type 2, which is strictly aligned with chondrocytes. It's more fibrous, the collagen is thicker, and it ensures for a stronger bond. The elastic cartilage, you have elastin fibers, it's more flexible. And you can imagine this would be useful in the ear or the epiglottis, which helps with swallowing. So we move on about cartilage injuries. So what are the different types? What's the typical patient? So as with any injuries, we have acute and chronic. So for muscular stuff, always think something that happens immediately and something that happens over a long time. So acute injuries, so this is from sports or trauma, whereas chronic is like previous injuries or osteoarthritis. Acute injuries are usually happening in younger patients, whereas chronic develop over time, so you usually have to be older for that. So the typical patient for a cartilage injury is a young male, contact sports, or a road traffic accident. So that's the sort of history you're looking for. So young male, contact sports, and road traffic accident. Chronic injury, so it's elderly, typically female, because you can have osteoporosis or history of arthritis. Arthritis is slightly more common in women than in men, especially as they get older. And this is because they have less estrogen, which means that there's fewer hormones to maintain the bone. So they will have more brittle bones, and therefore if you get a fracture, you might also hit the cartilage. You might also get drying up of the cartilage as people age, which means that there will be more immobility, or that the cartilage itself may be more inflamed, such as in rheumatoid arthritis. The question 4 here. So which investigations can be used to assess damage to cartilage? So investigations primarily with musculoskeletal, you're going to have your physical examination. So you'll have a doctor, move your joints, see how far you can move them, where does it hurt, they'll press on it. But in order to get a better picture, right, you want to have imaging. So the first sort of imaging you do is an X-ray. So for X-rays, you locate the fractures within the cartilage. Another good imaging is MRI. So MRIs are very good. They're very commonly used in musculoskeletal problems because they visualize the connective tissues and the finer tissues, whereas X-rays only show the bone. So you can locate the fractures. MRI can be used to confirm where the cartilage is damaged. And the most sort of interventional, so this goes in order of intervention. The most interventional would be an arthroscopy, which is where you're sedated, you're general anesthesia, and a surgeon, they look into your shoulder with a scope. So they have to puncture, skin, get into your shoulder and have a look around. And it's very invasive. So X-ray, least invasive. So that's what will be given to most people. You locate cartilage fracture. If it's a serious problem, you'll do an MRI to confirm the cartilage damage. And if you need like proper investigation because you're not sure what's happening, or you might want to repair the damage, so you do an arthroscopy to have a look inside, and then you can also repair it arthroscopically. And the image that you sort of see is, this is what you get. So this would be sort of like the cartilage here, and it's all flaky, and this is no good. So this means the cartilage has been compromised. There could be some damage to the surrounding tissue, so either the joint capsule or the surrounding ligaments, and it needs to get fixed. As you can see, this should be all nice and smooth, but it's open, and that's not good. So I think this is the final question here. Outline the different types of treatment options for cartilage injuries. So with anything musculoskeletal, anything in orthopedics, there's physical therapies, medical therapies, and surgical therapies. Physical therapies are going to be the best way to do to return function to the patient. For example, if you have problems with walking or pain with walking, and it's a cartilage and your joints and your synovial fluid is drying up, the best way to counter this would be to increase your exercise. Now there's a paradox, because you have poor mobility and you're in pain, therefore you can't exercise. But you can't exercise and you're in pain because you don't do enough movement. So it's a sort of vicious cycle, and this is why physiotherapy is so important. The first one will be physiotherapy, and we do range of movement exercises. That's what I mean by ROM, range of movement exercises. So the physiotherapist will help move, for example, if it's the hip, they'll move the full range of motion of the hip, extend and flex the hip. If it's the knee, flexion, extension. Then that's just basic movements. You have muscle strengthening. So muscle strengthening and aerobic conditioning makes sure that the muscles are stronger and that they can actually move the bones and the joints. So the sort of example you can think here applies both for acute and chronic injuries. If you have an acute injury in a young person, this means that they suddenly are in a lot of pain and cannot move, and therefore they need to regain that movement back. In an elderly person, they are going to be very stiff. They're going to be, they'll have less movement over time, so it's more of a gradual decrease in movement, and you want to sort of return them back to their previous best performance. Of course, it will not be as good as it was initially, but the key is here to get as big an improvement as possible. Finally, for physical therapies, we have weight loss. So because of a lot of pain and the inability to move, patients become sedentary or bedbound, and they may have gained weight. So weight loss may be a key sort of target, especially in patients with larger body habitus where their weight is limiting their movement and limiting their recovery. So weight loss programs may be encouraged. Now, in order to be prepared for surgery, you have to be quite fit, because if you have a lot of fatty tissue, you have something called metabolic syndrome, because the fatty tissue sort of acts like an endocrine organ, and it secretes cytokines and causes inflammation. So that's not good when you're trying to have surgery, because surgery is very demanding to the body, and it causes an inflammation for the whole body called a systemic inflammatory response. And you do not want this coupled with all this fatty tissue promoting even more inflammation. So weight loss has two purposes: to either improve function, so movement, and also to prepare them for their fitness for surgery. Now, medical therapies, it centers around pain management, steroid injections, and supplements. So pain management is through paracetamol and NSAIDs. So the NSAIDs target the COX-2 pathway and they remove pain. You can sometimes escalate this through something called the pain ladder, and you can give weak opiates such as codeine and tramadol, and you keep escalating until the pain is manageable. The goal here is that eventually you want to bring the pain down, and therefore you want to bring down the level of the medication. So the worst case thing is that the patient starts with paracetamol and you get them addicted all the way to morphine. That's not the ideal scenario. You want to sort of get them to the right medical medication that they need to reduce their pain and then bring them down. You have steroid injections. So steroid injections, they work by reducing the degradation. So it's the glucocorticoid, so it decreases inflammation within the joint. They're short-term pain relief. However, if they're given repeatedly, they become toxic to the chondrocytes. So the cells themselves do not tolerate steroids really well. So you have to be careful, because if you keep giving them corticosteroid injections, not only will there be a lot of pain and there will be diminishing returns, but you can do permanent damage to the cartilage. Finally, there's supplements. So there's different sort of supplements you can give, such as keratin and chondroitin or hyaluronan. The evidence for those is a little bit shaky. I know that some athletes take these to help them out, but if it's useful for the general population, the jury's still out on that. So they may be given it to some patients. Anecdotally, some patients feel better with it, but also some patients have no changes at all. So pain management and steroid injections may be more immediately effective. And then finally, we have surgery. So we can have arthroscopy, which we talked about. So this is looking through the scope and penetrating the tissue. And what you can do is that you sort of scratch the subchondral bone, or you penetrate the cartilage to the subchondral bone to trigger the sort of healing process. You can also do this through microfractures by scratching the cartilage a little bit. Another thing they do is cartilage transplantation. So this is more common in like the knee, like when you have menisci. So you take a cartilage from one part of the knee and you transplant to another part, so another part of the joint. And that can so healthy cartilage can be replaced. Healthy cartilage replaces damaged cartilage. Finally, we have joint replacement, which if the cartilage is really worn out, like in osteoarthritis, they remove the whole hip and they put sort of like a replacement for that. So it depends. It can be ceramic, it can be metal, depends. And this greatly improves daily living and daily function. So if people can't walk, suddenly they can. Of course, given the appropriate physiotherapy. Here's some pictures. So this is what it looks like to do the transplantation. So they cut off a piece of this cartilage here, and they sort of put it back in the other place, and they transplant it to sort of trigger the healthy cartilage to respond. And then this is a knee replacement. So as you can see, this is pretty gunky, pretty bad cartilage. And what they do is that they replace it completely with a prosthetic. So this is metal, and they recreate the joint here, and it ensures good movement. So this can help quite significantly and needs to be replaced in 5 years' time. Hips are better than knees to replace, but overall it's still a good procedure to do. So that is all from me. This video will be made replayable after the session. So please leave feedback on how we can improve the session. Next week we will be doing Zoom sessions from multiple tutors, and it will be across different topics. It will be limbs and back as well, so the upper limb, lower limb, and the spine, and it will be like a big session. So that's on the 11th, and then a week after that we'll be doing another year 1 session which covers all the phase 1 and cardiorespiratory things. So I hope that was helpful. If there are any questions, you can either email me, you can write to the Glasgow Clinical Anatomy email, or just leave them in the YouTube comments, and I'll get back to them and I'll respond. So if you have any other questions, do let me know. Now is the time to ask. And yeah, if there's any suggestions on things you want us to cover, then please let us know. Okay, if there are no questions, that's okay as well. But yeah, so every single session, so we have if this is the first time you're watching this, we have a whole playlist on limbs and back. We will be doing more videos as well on like vascularity, and I know that your exams are coming up quite quickly, so we'll also be doing some sort of shorter videos on questions and answering, like sample questions and model answers, to sort of give you a better idea what they might be asking you. But yeah, so general advice for the limbs and back, you want to stratify it into your bones, so you know about your bones, tendons, and cartilage. Those are your three sort of main tissues. Their repair and the cells, how they work, are very similar. It's just different names, so the processes are very similar. So once you understand one, you just apply the knowledge to the other. But yeah, if there's no questions, well, thank you for watching, everyone. I hope this has been helpful. If you've liked it, give it a like. If you subscribe, all that stuff, so that we can see that you like these sort of things, and so that you can keep up to date with our sessions. All right, guys. Have a nice day and good luck with your studies.